This conference will now be recorded.
So today we will be discussing two SIPs. That is, one is air travel in pregnancy and another one is vitamin D in pregnancy. Both are actually old one. One is 2013 and one is 2014 SIP. But I think the questions they are asked on it, one or two questions only, but there are like these are the two SIPs where you get the questions. Otherwise, other SIPs are very difficult. That you have some talk articles for it, and you have some other things like for CMV, SIP, NIPT. So all these things you have talk articles available. Okay, but these are the SIPs. These two SIPs you don't have any other source. Okay, so I'm taking these two SIPs. That is, one is air travel and another one is vitamin D in pregnancy. Okay. So we will start. I have taken very short, hardly with two SIPs. I have done hardly 14 or 15 slides. Okay. Sorry. Okay. So pathophysiology of air travel when we consider. So exactly what happens is the barometric pressure is significantly lower. Okay, at high altitude. So there will be a reduction in the partial pressure of oxygen. So there will be reduction in blood oxygen saturation also, and it is around by 10%. Actually, it doesn't affect the healthy people also in healthy pregnancies. Okay, but yes, the people who are hypoxic, okay, like severe anemia, sickle cell crisis, these people may be affected by this reduced oxygen saturations. But for normal people and normal pregnancy, it doesn't hamper much. But yes, there will be reduction in oxygen around 10% in the blood. Then also humidity is low at around 15% reduction in the humidity also in cabins. So also it will lead to increase in insensible fluid loss, but it is insufficient to cause the dehydration, but it may cause drying of mucous membranes. And another thing, the duration of flight, it will lead to increased risk of DVT and leg edema. Okay. So when this air travel, long haul travel is associated with other risk factors, okay, like obesity and different risk factors for DVT, and also with physiological changes, which is a hypercoagulable state of pregnancy is hypercoagulable state. So this air travel, other risk factor plus pregnancy itself, it increases the risk of DVT in case of air travel. So these are the basically three main important problems with this air travel. Now, what is the thing that in pregnancy till what timing air travel is allowed? So usually many airlines do not allow to fly women after 36 weeks. Why? Because actually there is risk of going into the labor on board. Okay, so while in the flight they may go in labor and they have to deviate the flight or they have to land inappropriately. Okay, so to avoid that risk, they will not allow the woman to fly after 36 weeks. Also for high risk, the women who are at high risk of preterm labors, so like multiple pregnancy, they also should not fly after 32 completed weeks. So these two things that you should remember. So for normal pregnancy, 36 weeks. For multiple pregnancy, 32 weeks is the limit for air travel. So also they should seek a specific advice regarding the air travel. Okay, so the women who are at high risk of preterm labor, they should seek expert advice. And another thing is, usually airlines require a specific letter from doctor or midwife after 28 week of pregnancy, so that stating that there is no complications. Okay, so that you have to tell, and also they have to take the letter regarding the EDD. Now, this is the important thing. Sometimes they may ask question regarding this. So what are the contraindications for commercial air travel? So remember these things. So first thing is severe anemia with hemoglobin less than 7.5. Okay, severe anemia with HB less than 7.5, recent hemorrhage in the pregnancy, otitis media, sinusitis, serious cardiac or respiratory disease, recent sickling crisis, recent gastrointestinal surgeries, okay, where there have been gastrointestinal procedures and anastomosis. So where the suture lines on the intestine. So basically it is for the where anastomosis or intestinal suturing has been done. Okay, so that can come under stress due to reduction in the pressure and gaseous expansion. Okay, so that intestinal sutures may give away. So for recent gastrointestinal surgeries, air travel is contraindicated. Also a fracture when it is the when it is in the cast. Okay, so because that because of significant edema and the this thing leg swelling, it will be difficult. Okay, so in first few days of cast, if there is in case of fracture, if it is a first few days of cast, again it is contraindicated. Now, the most important part of air travel is its VT risk. So, this prolonged air travel, it increases the risk. There is increase in the risk of absolute risk of VT or absolute incidence of VT only small. That is 18% higher risk of VT for each 2-hour increase in flight duration. 18% or threefold. Okay, threefold or 18% increase risk of VT with each 2 hours increase in flight duration. But the absolute incidence is only 1 in 4,600 flights in the month following flight of 4 hours. So if you are taking air journey of 4 hours, the risk of VT, absolute incidence of VT is 1 in 4,600. And when you wear this graduated compression stockings, okay, it reduces the risk of asymptomatic DVT with relative risk of 0.10 or 0.1. Okay, so this is the thing, that is that 18% you should remember, and absolute incidence you should remember, that is 1 in 4,600. Now, how you are going to minimize? Yes,
Ma'am, please explain that last line. What does it mean, ma'am? Relative risk of 0.1.
yeah. So what happens is a relative risk of 0.1%. So it will decrease by only 0.1%. Okay, it is not much. So whenever it is, when you say it is 0.1, so what you will tell, it is only 1 in 100, 0.1%. That means it is almost, it is less than 1 in 100. Okay. So it is not going to reduce the risk significantly, but yes, it is reduced by only 0.1. Okay, it is not very significant, but yes, it reduces the risk of asymptomatic DVT. Okay, but it is not very much this thing significant. Got it?
Ma'am, yes, yes.
So how you are going to minimize this risk of DVT? So first is have an ASL seat to facilitate the ease of movement. Take regular walks around the cabin. Carry out in-seat exercises every 30 minutes on medium or long haul flight. Maintain good fluid intake, hydration, minimize caffeine and alcohol. Okay. Make a specific individualized risk assessment for thrombosis. Okay. So it will give us another risk assessment when you are traveling by air travel, or for that matter any prolonged travel. There should be separate risk assessment should be made for thromboprophylaxis. Okay, and for medium or long flight duration, that is more than 4 hours, it is suggested that all pregnant women should wear graduated elastic compression stockings, and it should be properly fitted. Now, the women who have other risk factors, additional risk factors for DVT, like previous DVT, thrombophilias, and morbid obesity, medical problems like nephrotic syndromes, chronic diseases, so they should use low molecular weight heparin, and the low molecular weight heparin for the day of the travel and several days day after. Now they have not given the duration exactly for how many days you should give this thromboprophylaxis with low molecular weight heparin, but what they have told is actually the maximum risk is in the first 1 month. Okay, so they have not given the proper days, but several days after the travel. Okay, that low molecular weight heparin should be given when there are additional high risk factors. Okay, and other factors regarding the air travel is, so there is no risk of pregnancy complications like preterm labor, premature rupture of membranes or abruption. The radiation goes to fetus from flying, that is cosmic radiation as you call. So it is not significant unless there are frequent air travel occurs in pregnancy. So it is actually this thing for flight attendants, but it is not for the occasional travelers. Also, the body scanners which are used for the security checks, it does not pose a risk to mother or fetus from the radiation exposure. So these are the other factors which are important in this regarding this air travel. So this is regarding the air travel SIP. So these are the only points which are important in that SIP. There is no need to read the whole SIP. Now, vitamin D in pregnancy. This is also actually it is a 10 pages SIP, but no need to read all those things. So all you know what is this vitamin D? Its active metabolite is 125 dihydroxyvitamin D. Okay, and it has an action on calcium balance and bone metabolism. So if there is no sufficient vitamin D, the intestines cannot absorb calcium and phosphate, and it will lead to secondary hyperparathyroidism, and there will be lack of bone mineralization, which will result in rickets in children and osteomalacia in adults. So it is vitamin deficiency is common in Northern Europe, usually the woman with pigmented skin. Okay, and it is 3 times more common in winter and spring. Somewhere I have read this question. So vitamin D deficiency is more common in winter and spring, as we can this thing also when we use this common sense, because there will be no sunlight. Vitamin D3. Vitamin D3, that is cholecalciferol, it is produced from conversion of 7 dehydrocholesterol in skin, and vitamin D2 is produced in mushroom and yeast. The biological form of vitamin D is 125 dihydroxycholecalciferol. Okay, so this is the important thing that can ask us question. So biologically active form is 125 dihydroxy vitamin D. So first hydroxylation occurs in the liver and second hydroxylation in the kidney. Okay, so there are two. One is at the 25 and one is at the first bond. So first occurs at 25 bond and it occurs in the liver, and second hydroxylation occurs in the kidney. So the first hydroxylation product, that is 25 hydroxy vitamin D, it has a low biological activity, but it is the major circulating form. Remember that. So the 25 hydroxy vitamin D is hydroxylated in liver and it is the major circulating form. So the thing what we measure, okay, in the blood. So serum, the vitamin D, what we measure is this first hydroxylated form, okay, and it reflects the nutritional status. Now production of this secondary hydroxylation, it is tightly regulated by plasma parathyroid hormone levels, serum calcium levels, and phosphate levels. So second hydroxylation is very important, and it is regulated by parathyroid, renal, calcium and phosphate levels, and it occurs in kidney. So the largest source of vitamin D in adult is from solar synthesis from sunlight. So half an hour of sunlight delivers 50,000 international unit of vitamin D with white complexion skin. Okay, so half an hour of sunlight gives 50,000 international unit of vitamin D. It is much more than whatever is our daily requirement. Dietary intake of vitamin D, it is a relatively small contribution because there is a little vitamin D that occurs naturally in the food. Now, what are the maternal and fetal complications associated with vitamin D deficiency? So, it is associated with hypertension, preeclampsia, and increased cesarean section rate. So, maternal complications is hypertension, preeclampsia, and increased cesarean section rate. And it is the most common cause and potentially preventable cause of neonatal hypocalcemia. Sometimes neonatal hypocalcemia is also responsible for seizures, neonatal seizures. Now, routinely, this measurement of vitamin D in pregnancy is not advised. So, for routine pregnant woman, measurement, I'm not telling supplement. So, measurement is not advised. So, measurement of vitamin D should be done in woman with known hypocalcemia. Okay, so the woman who have history of hypocalcemia, woman who gives symptoms of bone pain, gastrointestinal disease, alcohol abuse, previous child with rickets, and those receiving drugs which reduce this vitamin D. Okay, so like the phosphate and this thing. So related to this parathyroid hormone, those who receive those drugs, there are chances that there will be vitamin D deficiency and their measurement is required. Now supplementation. This is the most important chart of all this SIP, and this is the last thing or last slide of this SIP. So remember, for routine pregnant patient, recommended for all pregnant women is 400 units, and it is 10 microns or 10 micrograms. Okay, so 400 corresponds to the 10 micrograms. For routine pregnant women, it is recommended. Okay, then high risk of preeclampsia. So high risk of preeclampsia, the dose recommended is 800 units. Okay, and the recommended for risk of that is which are at the high risk of vitamin D deficiency that I told you previously. Okay, where the vitamin D level should be measured. So for those, the vitamin D dose is 1000 international unit. Okay, and next thing is the treatment part. Okay, so when there is confirmed hypovitaminosis or vitamin D deficiency, you have to give 20,000 international units per week, that is cholecalciferol, or 10,000 international unit twice week of ergocalciferol. That is the dose that you should give in the deficient woman, and for that then it will be almost around 1,000 to 2,000 units per day. That will be the maintenance dose once the levels are replenished. Okay, so this is the second thing is therapeutic level, while the first is supplemental level, so that is 400 or it is 10 micrograms, 800 units or 20 micrograms. Okay, so this is the level, and this is the, I think, last slide of the slip. So we will go to the questions. There are 4 or 5 questions. These are available in different books. So first question is, what vitamin should woman be advised to take during pregnancy and breastfeeding? Yes. Answers, yeah. Yeah, now don't confuse between folic acid and this thing, because folic acid is advised, that nice advice only for first 12 weeks. Okay, only in some people they advise throughout the pregnancy. So don't go with folic acid, you have to go with vitamin D. Okay, folic acid is not advised for breastfeeding also. So it is, answer is D. Second thing, 42-year-old woman seen in booking clinic for in her first pregnancy. She has history of chronic hypertension. She is taking methyl dopa. She is white Caucasian, BMI 24. What is the daily dose of vitamin D? What that is recommended for her? Yeah, as I told you, so for normal it is 400. For high risk of preeclampsia it is 800. While the high risk of vitamin D deficiency it will be 1,000. Okay, so it is, the answer is the B. Which of the following statement regarding air travel in pregnancy is false? Yes. See, hemoglobin less than 7.5, definitely it is a contraindication. So it is a true statement. Increased cosmic radiant exposure is associated with flying is not considered significant. Correct? So as I told you, for occasional flights, it is not this thing significant. The key, so that is a true statement. Key change in environment is cabin humidity. Correct? So as I told you, there will be decrease in the 15% decrease in humidity. So that is also a true statement. There is 18% increased risk of VTE. Yes, that is also a true statement. They are asking false statement. So there is no increased risk of complication in air travel in pregnancy. That is a definitely false statement, because as I told you, there is increased risk of VTE. Correct? Answer is E. Next, 32-year-old second gravida, 16 weeks of gestation, about to take a long haul flight to attend a family function. Her previous pregnancy was eventful, but she had a cesarean section at term due to breast presentation. Which of the following condition is not a contraindication for her air travel in pregnancy? Yes, very good. So answer is A. Hemorrhage in previous pregnancy is not a contraindication, but hemorrhage in recent pregnancy or recent hemorrhage is a contraindication. So other all things are contraindicated. So answer is A. Hemorrhage in previous pregnancy is not a contraindication. And then I think this is the last question. So the recommended dose of vitamin D supplementation for women in pregnancy and lactation. So it is 10 microgram or 400 units. So 10 microgram corresponds to the 400 unit. So answer is D. So this is the last question. Yeah. So I think today we have finished. Any doubts?
Yeah, ma'am. Regarding the consent advisors, what all information we need to remember, ma'am? The last.
This conference will now be recorded.
Yes. What you want to tell? See, consent advice, the basically for percentages, all complications. Okay.
That last one page is enough, ma'am. Last one page of the consent advisors.
Last one page, I think in the first page also they have given some important percentages. So don't go for last thing. You read first 2 pages. That is more important actually. Hmm? Don't go for
Okay.
that form, consent form. Don't go for the consent form, but go for the first 2 pages, okay, where they have given the proper percentages. Okay. The last
Okay,
page
ma'am.
is about how you're going to explain that consent to that woman. Okay. The last page is about. Okay.
Yeah,
So
ma'am.
this is yeah. So no need to do that. This is for that is for the part 3. Okay.
Okay, ma'am. Thank you, ma'am.
Okay. Okay, then bye guys.